Good morning, good afternoon, colleagues. Welcome to this webinar regarding the strengthening of Ebola disease surveillance, the procedures for early detection, reporting, and response organized by WHO AFRO. I'm Dr. Saliu Jallo, I'm epidemiologist working with WHO AFRO under the Emergency Preparedness and Response team. I will be moderating this session, so it's really my pleasure to welcome you to this webinar. As you know, Ebola remains one of the most challenging public health threats in our region, and each outbreak reminds us that early detection, timely reporting, and strong investigation are really key to the transmission. So today's session is really to discuss about the surveillance. But before we begin the session, let me really thank all the panelists for the time dedicated to prepare and present the slide that you will be seeing today. So let's start with the housekeeping as usual. There is a WHO code of conduct. So WHO is committed to enable events at which everyone can participate in an inclusive, respectful, and safe environment. So the events that WHO are organizing are guided by the highest ethical and professional standards. And all participants are expected to behave with integrity and respect toward all participants attending or involved in any WHO event. So during this webinar session, the interpretation is available in English, French, and Portuguese. You can just go below to use the interpretation logo so that you can get your current language. You can also use the Q&A box for questions regarding the topic and the presentation. And also you can use the chat feature for general introduction and question regarding IT or logistics. So to take the floor, just use the raise hand feature. The moderator will invite you to talk. So for the participation, by participating in this meeting as a participant or as a panelist, we take your attendance as a permission to record your contribution and share the recording via various channels for learning purposes. For the data used, we collect data, the registration, participation, Q&A, and comment, poll, reaction, etc. And your individual data will be kept confidential. This data are used for M&E purpose. Now, let me give the floor to Dr. Etienne to introduce our Regional Emergency Director for the opening remarks. Over to you, Dr. Etienne.
Thank you very much, Dr. Saliu, and welcome to everyone to this important webinar. This really comes at the time when we are really facing a major outbreak, and we need to all align and see what exactly we need to do to strengthen surveillance on the ground. So this is a great opportunity to really discuss together and see what we can do to better support the response on the ground. So Dr. Etienne Kua, I'm the Program Area Manager for Health Emergency Intelligence and Surveillance at WHO AFRO and the coordinator of the Dakar Emergency Hub. It is a great pleasure for me to introduce our Regional Emergency Director, Dr. Marie-Roseline Belizer, who will give opening remarks and welcome all of you to this important webinar. So over to you, Dr. Belizer.
Thank you. Good morning, colleagues. Greetings from Bunia, the epicenter of the Ebola outbreak. So this is my pleasure to really share those opening remarks this morning in this really important, I can say, webinar today when we are discussing the importance of surveillance in order not only to prevent, to detect early, but also to respond to outbreak. So let me say again, good morning, distinguished colleagues, dear surveillance officer, partner, and member of the WHO Africa Region Response Community. It is really my pleasure to welcome you to this technical webinar on Ebola disease and surveillance, organized at a critical time, as mentioned by the PAM, when the region continued to face the risk of Ebola disease outbreak. So that including the current Bundibugyo Virus Disease situation that we are facing now in DRC and Uganda. So let me say that Ebola disease remains one of the most serious public health threats in our region. Its potential for rapid spread, I think you are following the outbreak now, the information, and you can see how the outbreak is evolving rapidly. Every day we have a new health zone affected, and the cases were an average of 20 cases a day, what is very high in an Ebola outbreak. So I can say that the severe outcome, the healthcare associated transmission, community disruption, and cross-border implication really requires strong, timely, and well-coordinated surveillance system. Experience from past outbreaks has shown us that the speed and quality of surveillance can determine how quickly transmission chains are detected, how effectively contacts are monitored, and how rapidly response measures are targeted to where they are most needed. And I can assure you this is exactly what we are doing now in this outbreak. And as you may know also, we have been a little bit behind of that outbreak. So now for the surveillance system to kick off in order to help us, I can say, contain that outbreak, know the transmission change is really a hard work. And surveillance officers, they are really at the front of this work that we are doing now. So chapeau to all the surveillance officers. So today's webinar is therefore very important. It provides an opportunity to strengthen our shared understanding of Ebola disease epidemiology and transmission, review surveillance standards, and discuss practical approach for alert detection, case investigation, contact tracing, data management, and analysis and reporting, which is also very important. I'm also sure that in that outbreak we are following that we were reporting like on suspected cases. And now the suspected cases have joined dramatically, and there are some concern asking why we have changed the data. We have not changed the data. We only applying a surveillance rules in order suspected cases couldn't be forever suspected cases. They have to be, they become confirmed or non-confirmed cases. And after that, they are not really count anymore in the suspected cases on go. So it's really why I would like to emphasize the key message at the start of this session. First, early detection save lives and limit transmission. Now, every alert, every unusual death, and every suspected case must be rapidly detected, verified, investigated, and linked to laboratory confirmation and response. Secondly, surveillance must be risk-based and coordinated. We cannot doing surveillance for, just like that. We need to know the risk. For example, now in this outbreak, we are doing the risk analysis in order to inform our surveillance and response. So I also want to say that countries reporting case require full surveillance activation within the national response. Neighboring and high-risk countries must move to enhance readiness, especially in border area and morbidity corridors. Other countries must maintain vigilance through IDSR and IHR channels. As you must know, this outbreak has been declared as a fake, so that means all countries need some kind of preparedness. And thirdly, data must driven action. Surveillance, it is not only about collecting information, it is about transforming alert, case data, laboratory result, contact monitoring, and field investigation finding into timely decision and that interrupt transmission. And I would like to add another one. It is also the movement of the population. Because one of the things that we are seeing in that outbreak here in DRC is that mobility is playing a key role, and it should also be inform our surveillance system. We have an analysis where we use a Vodacom data, and it shows us how the cases are moving, the contact are moving, and we can follow that. So it's really important because when the contact and the cases are moving, so they are carry with them the risk, and the surveillance should follow that risk approach. So WHO will remain fully committed to support all member states to strengthen the Ebola disease surveillance, to enhance readiness, improve cross-border coordination, and make sure that surveillance systems are able to quickly detect, verify, and respond rapidly to any compatible alert. I really encourage all participants to actively engage, ask questions, share your practical country experiences, and because there is not a single, I can say, context is also important when you are looking at surveillance. Culture is also important when you are looking at surveillance. I don't know if I have time, but if you look at the story starting here, there are so many, but one of them that also give me a tick is that at the starting point when they see some hemoptysis in the blood in their vomit, they thought it was tuberculosis, so which is also fair. The reason why it's really important that the surveillance also can be really risk-based and also take into consideration not one disease, but also other diseases that are, endemic also in the community where we are putting that surveillance in place. So I really encourage that the value of this webinar will come not only from the presentation that you will be listening to, but also from the exchange that you will engage between countries and the technical team in WHO. With this remark, I really wish you a productive and interactive session, and I thank you once again for your continued commitment to protecting community across the African region. So thank you so much and have a fruitful webinar. Over to you, Etienne.
Thank you very much, Dr. Marie-Rosaline Belizer. This is really a powerful message, and we are very happy that you were able, despite the very busy time in Bunia, to really open this webinar. So thank you again for that. At this point, I will pass it over back to our moderator, Dr. Saliu, to continue with the program. Thank you very much, and over to you, Dr. Saliu.
Thank you very much, Red and Pam, for your kind introduction and opening remarks. So now just let's look at the agenda. So the first topics will talk about the objective, which will be presented by Dr. Paul Ouma. This will be followed by an overview of Ebola disease epidemiology, which will be presented by Dr. George Williams. Then the EVD surveillance standards will be presented by Dr. Emmanuel and Dr. Freddy. The data management and reporting will be presented by Tamai. After that, we'll be having a session on Q&A. And for the wrap-up, Dr. Etienne will talk about the surveillance priorities for the WHO AFRO region. So with that, let's start with the objective. So Dr. Paul Ouma, which is the team lead for data systems and analytics in WHO AFRO, under the EPR and the Health Emergency and Surveillance Unit will be presenting. Dr. Paul, over to you.
Thank you so much, Saliu. Good morning, good afternoon, colleagues. So we will quickly go through the objectives of this webinar and also some of the expected outcomes after we are finished within the next 1.5 hours or so. So our main objective is to strengthen the capacity to implement effective Ebola disease surveillance, especially focusing on the procedures for early detection, reporting, investigation, and response. And we will do this through 3 key objectives that will center around the presentations we have today. The first one will be to enhance our understanding of the epidemiology of the current Ebola disease outbreak and the transmission dynamics. So we will be taken into details on how the epidemiology is as per the data that we have. Then secondly, we will also update our knowledge on the standard Ebola surveillance procedures, including case definition, alert verification, case investigation, and also contact tracing. Then the third objective will be for us to promote the best practices in data management, reporting, and surveillance data quality. And with us, we have a distinguished team from the WHO AFRO EPR program, but also very grateful to the training team, and also, as Sally mentioned, the translation is there. Next slide, please. So at the end of this webinar, what do we expect, or what should we be able to do as participants? Number one is to be able to correctly apply Ebola disease standard case definitions and also case investigation procedures. But also, secondly, is we should be able to demonstrate adequate understanding of Ebola disease surveillance. And like I mentioned, this includes both all the components, that is alert detection, notification, investigation, reporting, but also contact tracing procedures. And then finally, we should be able to improve surveillance data recording, reporting, and analysis practices. And we will have a team that will also present some of the examples of our data tools, how we can record data, but also some of the analytical products that we can be able to produce. Finally, the main outcome is, as has been mentioned by our regional emergency director, is to have to move the needle in terms of improving our surveillance teams across Africa to be able to stop outbreaks before they spread. Thank you so much, and back to you, Dr. Sally.
Thank you very much, Dr. Paul Ouma. So as you can see, dear participants, let's be careful and follow what will be presented today. So now let's move the first presentation, which will be done by Dr. George Williams, who is the Public Health Intelligence and Risk Assessment Lead in WHO AFRO. So just a reminder that the Q&A question is here for you to use to ask all the questions that you want. So Dr. George, over to you.
Thank you, Sally. Good morning, good afternoon, dear colleagues. Based on your location, can you confirm that you can see my screen?
Yes, we can.
George, if you can put it in a slideshow, this shows the presenter's mode. So you can click on the points there and show duplicate tabs.
Okay.
Yeah, no.
I hope it is okay now.
It's
yes,
coming. Yeah.
it's perfect.
Okay.
Thank you.
Okay. So, dear colleagues, I'm going to talk briefly on the epidemiology of Ebola disease and also provide a brief update on the Bundibugyo Virus Disease outbreak that is currently unfolding in the Democratic Republic of the Congo and Uganda. So when we talk about Ebola, we are talking about a severe viral hemorrhagic disease that is caused by the filoviruses These are RNA viruses that belong to the genus Ebola virus. The fruit bats are thought to be the reservoir of Ebola, that is, they carry the virus without themselves being affected. And normally in the emergence of an outbreak, what happens is that there is a zoonotic spillover from the fruit bat to sometimes non-human primates like chimpanzee, gorillas, or monkeys who themselves get infected and transmit to humans or directly to humans. And outbreaks amongst humans are normally propagated by transmission that involves direct contact with the infected individual body fluids or materials that have been contaminated by that infected individual. There are 6 major species of the Ebola virus. 3 of them have been responsible for major outbreaks: Ebola Zaire, Ebola Sudan, and the one we are currently dealing with, Ebola Bundibugyo. But there are also the Thai forest, which have caused a single case. That was actually a laboratory incident in Cote d'Ivoire in 1994. And there are 2 others, Reston and Bombali. No outbreak or human case have been reported as a result of these 2 species. Now, in terms of the key epidemiological features of Ebola disease, this disease is normally characterized by a high case fatality ratio. That is the proportion of people who die from the disease. And this can be as high as 90% in some cases, particularly when detection is late and treatment is commenced very, very late. Another key epidemiological feature is nosocomial transmission. This is where we have transmission in healthcare facilities, particularly when infection prevention and control standards are not optimal. Also, Ebola outbreaks are normally characterized by funeral-related transmission. We know that viremia in people infected with Ebola who die is very high, and because of some traditional or cultural practices in some settings, interacting with that body can be a major amplification event during outbreaks of Ebola disease. So here I've tried to just show you that since 1976, when the Ebola virus was first discovered, there have been 24 major outbreaks in Africa. Most of those outbreaks have been caused by the Ebola Zaire virus, 15 of them actually. And we have had 6 outbreaks caused by the Sudan virus. The Bundibugyo we are dealing with, this is only the 3rd outbreak, 3 outbreaks so far caused. And in the history of this disease, the largest outbreak has been the outbreak of 2013 to 2016 in West Africa, particularly Liberia, Guinea, and Sierra Leone, where we have over 28,000 cases with more than 11,000 deaths reported. And the second biggest was from 2018 to 2020 in the Democratic Republic of the Congo, where we have over 3,400 cases with more than 2,200 deaths reported. So these have been so far the largest Ebola outbreaks to date. Now, in terms of the Bundibugyo virus disease outbreak, there are 3 to date. The current one is the 3rd outbreak. The first was in 2007 to 2008 in Uganda, where we have 149 cases with 37 deaths. The second was in 2012 in the Democratic Republic of Congo. So we are having a new outbreak after 14 years of the last outbreak in the Democratic Republic of the Congo. So the key message here is that Ebola outbreaks remain recurrent public health threats in the African region. So let me quickly transition to what we are seeing in the current outbreak. So as of the 2nd of June, There have been 363 confirmed cases with 62 confirmed deaths reported from the Democratic Republic of the Congo, whereas in Uganda, there have been 15 cases with 1 confirmed death reported from Uganda. And just to say that the outbreak in Uganda is epidemiologically linked to the outbreak in the Democratic Republic of Congo, because these cases in Uganda are people who were exposed in the Democratic Republic of Congo, traveled to Uganda and were detected in Uganda, and also cases that have been reported amongst their contacts. So what you see here is the trend, the cumulative trend in the number of confirmed and suspected cases reported to date. So from the beginning, you were hearing a high number of suspected cases, up to over 1,000 suspected cases reported from the Democratic Republic of Congo. As you know, epidemiologically, suspected case is a transitory category. At the end of the day, you will have to go either into the confirmed compartment if you are tested positive. You will be dropped as a non-case if you are tested negative, or you could go into the probable compartment. So the reason why you see that yellow line increasing over time is because we have a number of suspected cases being reported, but we didn't have enough tests, so this number accumulated over time. But at the time of testing, we have been able to rule out a number of them, which were actually non-cases, so you start to see that number dropping. And basically what you see now is the cumulative number of confirmed cases increasing over time. On the right is the trend, is the daily number of cases being reported from Uganda so far. So here, I'll just try to show you that 2 countries are affected so far. This is just to show you the geographic distribution of the cases. In the Democratic Republic of the Congo, cases have been reported. It's the most affected province with 17 health zones affected. North Kivu 7 and South Kivu 1. And the bar graph you see on the left quoted from each of those health zones, and you can see the top 4 is where we have majority of the cases, and they're reported at the moment in Ituri, where we can say over 80% of the outbreak cases are concentrated. And then in Uganda, there are 2 districts reporting cases, Wakiso and Kampala. So when you look at the map on the right, you can see the concentration of cases across these 3 health zones, in Ituri, in North Kivu, and way down below in South Kivu. In the Democratic Republic of the Congo, what we've also seen is geographic expansion of the outbreak. So by the 18th of May, there were few health zones reporting cases, and over time, you can see that these shaded areas, which are health zones with confirmed cases, increasing over time. So from the 18th, we had 3 health zones with cases, and by the time we got to the 1st of June, we have now 25 health zones. So this outbreak has also been characterized by geographic expansion across 3 provinces in the Democratic Republic of the Congo. So as WHO, we have assessed the risks associated with this outbreak. We've looked at the public health impact of this outbreak. We've looked at the risks of spread. We look at the capacities in place to respond to this outbreak, and we've done 2 risk assessments so far. The first risk assessment was based on the initial information provided. At the time, the national risk level and the regional risk levels were assessed to be high, and the global risk level assessed to be low. In the second version, based on what we know now in this outbreak, the risk level nationally in the Democratic Republic of the Congo has been increased from high to very high. The regional risk, including that of Uganda, remains high, and the global risk remains low. So as you also know, the Director General of WHO has declared this outbreak a public health emergency of international concern. That declaration means that this is an extraordinary event. And that declaration was based on the current scale and the transmission risks associated with what we are saying. So at the time, we had outbreaks in Ituri and North Kivu. Now it is in 3 provinces, with South Kivu also joining that list. We also have seen cases exported to Kampala, Uganda, where there have been 15 confirmed cases reported so far. But this outbreak has been characterized by a cluster of community deaths across these affected provinces, have been characterized by nosocomial transmission, number of infections among health workers. The epidemiological link amongst cases is still being explored. Even amongst samples that have been tested, positivity rate is still very high. Another important factor to consider is the context in which this is happening. This is happening in a place with high level of insecurity, population mobility cases. Some of the hotspots we are talking about are urban and semi-urban areas with high population density. There's large informal networks. So all of these are really increase the transmission risk and complexity for responding to this outbreak. I also want to mention that we are talking about a particular Ebola virus species that has no approved, no licensed therapeutics and vaccines at the moment. So in this public health emergency of international concern declaration, it was made clear that this particular event constitutes a public health risk to other state parties through the international spread of disease, and it requires international coordination and cooperation. So just before I end, WHO have provided some advice to member states as this outbreak unfolds. First, for those countries that are currently affected, the Democratic Republic of the Congo and Uganda, to activate emergency coordination mechanisms and strengthen multi-sectoral response, to intensify surveillance, contact tracing, laboratory testing, and rapid case isolation, strengthen IPC measures, healthcare worker protection, enhance community engagement, risk communication, maintain adequate supplies of PPEs, strengthen border health screening, as well as support clinical trials and preparedness for vaccines and therapeutics. And now for many of the countries, many of you who are on this call are coming from countries that are not affected but are at risk. So WHO is advising you to enhance preparedness that includes surveillance, laboratory readiness, and rapid response capacity. You need to increase community awareness and screening at points of entry, ensure readiness for isolation, case management, and contact tracing, avoid unnecessary travel and trade restrictions or border closures, provide travelers with information on risk and preventive measures, and prepare to support medical evacuation and management of exposed persons if needed. Thank you very much, and over to you, Sally.
Thank you very much. Thank you very much, Dr. George, for this great presentation regarding the overview of Ebola disease epidemiology. As you can see, to contain an outbreak like this, we need really multidisciplinary team that will follow the international guidelines so that the evidence-based decision-making will be conducted. Now, let's continue with the next session, which is about about the surveillance standards for Ebola disease, the case definitions, alert detecting, and management. So over to you, Dr. Emmanuel, which is our epidemiologist and IDSR consultant for WHO AFRO on the HIS EPR team.
Yeah. Thank you very much, Dr. Saliu. Please kindly put it in a slide mode. Yeah. So it is expected that by the time we finish this session, you should be able to identify what needs to be in place for effective Ebola surveillance, and then you should be able to correctly apply the Ebola case definition, and then the various procedures that you need to follow in managing alerts, and then understanding the steps when you suspect a case, and then when it's confirmed, what needs to be done. Please, next slide, please. Yeah. So we need to refresh our minds about the surveillance cycle. That is from detection to response. So we are aware that it's very, very important for us to initiate detection by using the standard case definitions. And once you identify a case, you need to report immediately to the next level through the existing IDSR channels. And then it's very important to verify all alerts and then send samples to the laboratory and then immediately start our response. Next slide, please. Yeah. So let's ask ourselves, how do you detect and report Ebola case or cases? First, it's very important for you to have established an alert system. And we're looking at some key areas. The major points of entry is, example, the land border crossing, especially if we are with the neighboring countries where cases have been reported, airports and seaports. So we need to train the point of entry staff in Ebola case definitions, and then ensure that we mount screening at all these points of entry. And then at the healthcare facilities, we need to enhance facility-based surveillance, first by ensuring that all these health facilities have case definitions for Ebola, and then train the health staff in the correct use of the case definitions. And then we need to build their capacity in early identifying the signs and symptoms of Ebola. And we need to enhance immediate reporting through the existing IDSR channels in our respective countries. And at the community level, we need to enhance community-based surveillance by ensuring that we identify and train community-based surveillance volunteers or community health workers or any key informants that we can identify and train them in the alert case definition and then how to report. And we need to also sensitize the general public on the community case definition for Ebola, which we see very soon. The key principle here is that we need to detect early, report fast, and respond effectively. It's important to know that every alert matters. Next slide, please. So now let's try to look at the steps for establishing an alert system. So first, we need to establish event-based surveillance hotlines and media scanning. What that means is that we need to have identify hotlines, establish call centers, and distribute toll-free phone numbers to the general public, where the general public can call in, can send messages, and people train to receive these calls and then report on these alerts. And once we detect any alert, we need to register them, conduct triaging, and ensure that we verify these alerts to determine whether they are true or non-true alerts, and then conduct risk assessments. And for you to be sure that your alert system is working, you need to apply regularly these monitoring indicators. Try to know the number of alerts detected, out of which the percent that have been verified within 24 hours, and then the percent that has been investigated within 24 hours, and then the number that have been converted to suspected cases, and then the number of laboratory confirmed, and then the timeliness of reporting. Next slide, please. So now let's try to look at the Ebola disease standard case definitions. They are in two parts. The one we use during routine surveillance, that is countries that have not reported any confirmed case of Ebola as at now. And then when there's confirmed outbreak, which of the standard case definitions will you use? So now let's look at the routine surveillance. For routine surveillance, a suspected case is any illness with onset of fever and no response to treatment for unusual causes of fever in the area, and at least one of the following signs: bloody diarrhea, bleeding from gum, bleeding into skin, bleeding into eyes and urine. And when a suspected case have a laboratory confirmation by positive PCR, then we say it's a confirmed case. Now, for the alert case, which will be used mainly in the community-based surveillance, where we will use it to train the community-based surveillance volunteers, community health workers, and so on. They are in three parts. The first one, illness with onset of fever and no response to treatment of usual causes of fever in the area, or at least one of the following signs: bleeding, bloody diarrhea, bleeding into urine, or any sudden death. Next slide, please. Now, during outbreak, a suspected case can be defined in four specific areas. One, any person, be it alive or dead, suffering or having suffered from a sudden onset of high fever and having had contact with a suspected, probable, or confirmed Ebola case, a dead or sick animal, or any person with inexplicable bleeding, or any person with sudden onset of high fever in at least three of the following symptoms: anorexia, diarrhea, muscle aches or joints, stomach pain, difficulty in breathing, hiccups, or any sudden inexplicable death. That's any death that occurs that we cannot explain. And then for a probable case during outbreak, any suspected case that has been evaluated by a clinician, or any disease suspected case where it has not been possible to collect specimens for laboratory confirmation, having an epidemiological link with a confirmed case. And a confirmed case is when a suspected case or a probable case with a positive laboratory results. And a known case is any suspected or probable case with negative laboratory results. Next slide, please.
Dr. Emmanuel, you have 3 minutes remaining.
Yeah. So for the response measures that need to be in place, we need to establish, first, well-trained rapid response teams in Ebola case definition, investigation, and reporting. And then we need to set up a fully equipped isolation centers with dedicated staff. And then identification of a national or international WHO accredited reference laboratory. Next slide, please. Yeah. So now, how do we manage the alerts? So when we detect any alert which is compatible or any unusual death, we have to report to the next level immediately and deploy rapid response teams within 24 hours to conduct the investigation. First, they have to verify whether there's any exposure history, line list the case and contacts, and then also document the deaths and links. And they have to ensure that they apply infection prevention control measures. And when doing investigation, this case meets a case definition, then it should be managed as a suspected case as we wait for the laboratory outcome. So this suspected case has to immediately be isolated. We need to complete the case investigation form, collect specimens to the laboratory, and then start contact listing. And when the lab results comes out to be positive, then it's declared as a confirmed case. Then we need to activate these response measures. We need to notify the national coordination and WHO channels, maintain the isolation and care, and then, very important, monitor contacts for 21 hours, 21 days. If there's any high-risk contacts, we need to quarantine them. And then we have to start active case search, do mortality surveillance, and also transmission chain analysis. And we need to begin setting up fever and other Ebola symptoms screening and hand washing at all the entrances of health facilities. However, if the lab result becomes negative, we need to continue to retain the case, and then we take a second sample. If it comes out to be negative, then we need to consider alternative causes and stop contact tracing. Next slide, please. So in summary, these are the key takeaways. We need to understand that we need to detect early by establishing a well-functioning alert systems at all levels and apply the standard case definition consistently across all levels. And remember, reporting fast is critical, and be prepared to respond. Thus, we should have a functional response structure, train RRT, equip isolation centers, lab. And then we need to respond fast, investigate all alerts within 24 hours, isolate and investigate all suspected cases immediately, and ensure adequate IPC measures. We need to remember early detection and early effective response saves life. Thank you. Over.
Thank you very much, Dr. Emmanuel, for reminding us those case definitions and how to be ready, how to use them and how to be ready when there is an outbreak. So thank you very much. Now let's move a little bit in detail regarding the case investigation and contact tracing, which will be presented by Dr. Freddy Banza, who is an health response emergency officer at WHO AFRO under the emergency response team. Dr. Freddy Banza, over to you.
Okay, thank you, colleague. So before to start, I would like to say that in Ebola outbreak, every case have a story, and every contact represents a potential opportunity to stop a transmission. So today's presentation or session will focus on some practical tips on how to conduct a high-quality investigation and effective contact tracing, which remain the cornerstone of outbreak control. So you can forget everything, but if you did not do a good investigation or a good contact tracing, so you will not control your outbreak. So the general objective is to explain how to conduct contact tracing to effectively control the Ebola virus disease. And then by the end, we should maybe, I've said it, know how to investigate the case very, very well, and then to describe contact tracing, how it should be conducted in the context of Ebola, and explain how to use investigation form and contact tracing tools. We can also analyze and maintain quality assurance during contact tracing related to Ebola virus disease. Next, please. So as you can see in the slide, and my colleagues have explained it, when you get, you receive an alert, you have the source of alert, the time, the location, the reason why you've been called. So the first thing is to conduct your investigation. You will be called to go, and then because those are two teams, a separate team, you can be called to go and verify and validate the alert. So you need to know if it's a live case, it's a dev, who is presenting the symptom? Is there any appealing? So there are two main, when you are investigating, you have to know, where am I? Am I in a certain area where they are notifying cases, or I'm like in a country of risk? If like today, the way we learned it, I think previous day ago in Ethiopia, one suspected case. So there is no Ebola there. The investigation should not be the same as if you are in an area where there is appealing, like in Ituri, in North Kivu, or in DRC in general. So you have to investigate the patient, and then to look at what are the clinical symptoms that the patient have, what are the movement of patient, what are the exposure, so that you can try to make a difference between the two. Because we said it and then the red said it, the mistake that was done, which is also normal, they thought for the Bundibugyo that we had in Ituri that it was tuberculosis, which is normal, but you should always consider the context of the country and the risk factors. If I'm in Capo Verde and I've seen someone who is bleeding, I have to know and then to look at what can be the exposure, what was the last movement of the person. So, and from there, I can decide and then say, okay, this person is coming from DRC and there is ongoing investigation in DRC, I have to do something. But if you are in DRC and then you have someone who is bleeding, so obviously you'll think the first thing will be Ebola, and then you'll go for your test, and then you send the patient to the ET. So this is just to tell you that you need to act as FBI somehow. So you need to get every single information on the person, where the person have been, where the person coming from, was he in the contact with someone, and then when you have all those answers, and then you can try to isolate the patient in any way, isolate the patient, and then to refer the patient so that the sample can be collected and then tested at the lab. So for each investigation, you should quickly answer these questions as you can see them there. Who is the patient? Who is he coming from? What symptom is he presenting? Where has the patient been? What exposure? Who may now be at risk? If you respond to all those questions, and then you have done very well your investigation. So sometime if you want to go further in investigation, do not wait that you get the lab result so that you can, there is always what we call the recall bias. So you have to start asking questions and whatever. Next, please. So you need to get the name, the age, the sex, the phone, the full address. Sometimes even the GPS coordinators, and then occupation, all the details about the person, the vaccination status, if the person was vaccinated against what and whatever. So you need to have all those information on patient identity. You need also critical information. When I'm talking about the GPS coordinates, it's very important. It wasn't in Ebola, but yeah, the Red said it. They are using now the Vodacom, and then maybe to track some of the contact. So it's very, very, very important to locate the person. So you have to know the date of symptom, if the person presented the symptom that were reported in the case definition. So, and then you have to know the current status. Is the person hospitalized when they call you before to go there? Is the person isolated? Is it in the health facility? Has the person visited the health facility when the person was admitted and when the patient consulted the medical doctor? If you miss any of this question or any part of this, and then you cannot control the outbreak. Why? If, like, I give you an example, the person went to see a traditional healer, and then you miss that part, it means the traditional healer will not list it as a contact, and then will continue also when he will develop the symptom to spread the disease. So it's very, very, very important. So you have to know the suspected person, if he went for funeral, if he traveled, if he, you need to get any single, and then we have that one tool that we call a mapping tool. So we have to track every single movement of the person before, just at the time he started having the symptom. If he went to church, and then you record all those people he met, those people will be registered as a contact. So use some date so that the person can recall, like, okay, was it when you went to church last time, when the symptoms started? Because some of the people, you know, cannot remember very well, and then you have to ask them and give them some of the references so that they can recall and give you the accurate information so that you can really have a success in your investigation. Next, please.
You have 3 minutes.
So, which kind of keep probing questions for EVD risk assessment? Contact with a sick person or a person who is already confirmed or not. So you have to know, as I said it, the relationship, the contact date, the status of the person, the type of contact with the person. If the person was in contact, you go for investigation. They're telling you that someone is presenting the symptom. You have to know very well he was in contact with a case in which particular conditions, so that you can really have all the information. And if it was like a funeral or burial participation, was the body touched, washed, carried? All those are important so that you can classify very well and then assess the level of risk. As I said, in the hospital, you have also to know when the person was admitted. Why? It's important because the same day when the patient was admitted and then he started presenting the symptom, all those patients that visited the hospital that day can be considered as contact. So you need to know that when you are conducting your, I know you know all these things. We are just trying to refresh you so that you can know very well. You can have some tips so that you can conduct an effective investigation. Next, please. So these are some of the tools that you can use and forms that you can use when you are conducting an investigation. When you are called for an alert, we have what we call always a short form that can be used. You go and then try to ask some questions and whatever, so that you get the information. I think they will give you a presentation where this tool will be presented, and then you have a long form, you know, where you can go in details and ask questions, especially when the result came positive. You have to go back again to the person and then start asking additional questions so that you get any single information that can help you to have people who might have been in contact with the person, so that you can list them and then try to follow up them so that you can break the chain of transmission. Otherwise, you are out of the track. So you need to notify, you need to investigate, you need now, when you investigate, you finish, you collect the sample, isolate. You are not going to collect the sample, you collaborate with people that are going, the lab people, they are going to, refer the case and then collect the sample, and then we'll start the listing of contacts, and then you report. Next.
Please took 1 to 2 minutes to wrap up.
Okay, so this is what a completed investigation must produce. So I've said it, isolation, lab, and whatever. Next, please. So we will talk about the contact tracing. A good way, what is the contact tracing? Is a process of identifying and controlling all the contacts. So you need to classify them very, very well. And this is very, very, very important. You need to classify them. There are contacts that are at high risk and low risk. No risk at all. We have also that category if they are not compatible exposure after verification. But those ones who maybe touch the fluid and unsafe burial and direct maybe did not protect themselves when they were taking care of the patient might be considered as a high risk contact. You have all this in the case definition, and then you can have a look on that. Next, please. So, as I said, you need to identify the contact to have all the information on the contact, because those contacts will become the probable cases in the future. So you need to have all the details when they become ill, and then you will just relay on the information that you collected so that you can follow up them. So your interview should be very, 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 very well conducted, and you should visit the household, and then if they are in the community, you should also try to locate them so that you can follow up them. You need to notify, to educate, to explain the risk, 20 days follow-up, symptoms, how to call for help in case of any symptom. They have to know all that, and then implement the daily follow-up. So a missed contact can sustain transmission. I've said it. Next, please. So these are the forms that you will have a toolkit, or people we always have a toolkit with forms for contact tracing, and they are contacts that we cannot maybe. They can tell you that they were someone was in contact with somebody who was confirmed, but you cannot see him. And it's very, very important. You have to list all the contacts. Even if you haven't seen them, you have to list them on your list. That's very, very, very important if you want to break the chain of transmission. So this presentation, it's just from case identification to the case release. It shows how you can identify your case, and then how you can release if the person after 21 days does not present any symptom. You might consider the person as not suspected and continue to investigate on other potential contact and cases. Next, please. So this is what I can give as a key takeaway for contact tracing. Every eligible contact must be identified, listed, notified, and followed up for 21 days. And then we need to start contact tracing immediately after we've been told that the person is confirmed, or is suspected, probable, or confirmed. We need to start the process of listing and whatever. So we should not wait too long. We need to review forms every day to find missed contact, symptomatic contact, low contact number, and some of the gap. As I said, some of the contact you might not see them for 2 days, for 3 days, and then you have to coordinate so that you can, find them. And in average, I will finish by there. We have some publication, and then from the Ebola in West Africa, we had 20 to 50 contact per case, but in DRC, the average was the mean was 15 to 30. But please keep in mind that a single case can produce up to 300 contacts. The maximum, it can even go up. So there is no limit. You have to list all possible contacts so that you can really control your outbreak. What I've given is just average. It means that you cannot, for an outbreak like this, when you have a confirmed cases, and then just try to have 1 or 2 contacts. No, if someone presents you a work like that, you must just ask yourself if you have done a good job. So there is a team that need to be formed to do this work. Normally, you should rely on the health local workers. That's those people, they know the community, they know the household, they can go and then follow up the contact so that you can have a good result instead, rather than taking people from very, very, very far to follow up your contact. So the contact, as I said at the beginning, is a cornerstone. The contact tracing and investigation is a cornerstone of the control of an outbreak. Thank you so much. I think we will stop there. We have a lot to do, but we cannot do it in 1 hour.
Thank you very much, Dr. Freddy, for this very important topic regarding case investigation and contact tracing, which is very, very important, but also the most difficult one because you have to work with community. Now, let's continue with the data management and analysis, which will be presented by Mr. Tamai Mlanda, who is a data science and business analyst in the WHO AFRO. Mr. Tamai, over to you.
Thank you, Saliu, and I hope you can hear me well and see the slides.
Yes.
Thank you. So good morning, good afternoon, everyone. In this section, we are going to look at the data management reporting and analysis during Ebola outbreak response and how data supports operational decision-making from community alerts all the way to response coordination. This diagram summarizes the outbreak data ecosystem. We can see on the left a number of activities happening at district level in the field where data is generated from multiple activities, from community alerts, case investigation, contact tracing, lab testing, case management in the Ebola treatment centers, and other activities conducted by other response pillars. These data streams are then integrated, analyzed, and transformed into various information products such as dashboards, maps, epicurves, and other tools that help to support operational decision-making. The main purpose for the data management pillar would be to manage the data and help response teams to make faster and better operational decisions. This includes helping to ensure data quality, ensuring harmonization of the data, confidentiality of data, We know that there are a lot of sensitivities around the data for private identifiable information, and also taking care of the need for managing the interoperability of all the tools and platforms that are being used, ensuring timely reporting of the data. We know that delays or inconsistencies in reporting data can directly affect surveillance, they can affect coordination, and they'll affect our response operations. One of the realities during outbreaks is that data will be coming in from many, many places at the same time. There'll be a lot of activities that are happening concurrently, and we'll be receiving information from the surveillance teams, from lab, from contact tracing, from the case management, from points of entry. The GIS teams are trying to manage boundaries and shapes so that they can produce accurate maps. And increasingly, we are also starting to see genomic surveillance, which is conducting sequencing to try and identify the pathogen and help to arrest transmission. One of the major challenges is bringing all of these fragmented data streams together and to paint a single operational picture. Once these different reporting streams are integrated and the data is cleaned, the next step would then be turning this data into operational intelligence. One of the first things that our coordination teams, the epidemiology teams are looking for at every morning is the epidemiological curve. So this is a tool that helps us to understand whether cases are increasing or declining. Are we seeing more deaths? Are we seeing how is transmission evolving? Where are peaks occurring? And also to correlate whether our interventions are having an impact. I have included this, it is a slide from 2014, but we can clearly see how we can look back at the data and try to tie the interventions that were happening to the progression of the outbreak. We also conduct spatial analysis, which is extremely important during Ebola outbreaks. This helps us to understand where the hotspots are. It helps us to understand the geographic spread. It helps us to correlate different pieces of data. We can visualize migration patterns, overlay them with maybe where we see key landmarks such as the mines, and try to see what the transmission corridors are. These products help to guide field deployments as well as the targeting of our interventions. We also have the external situation report. This is a consolidation of all the different pieces of information into a summary product. This provides a high-level operational picture, which summarizes the case counts, the lab results. It summarizes the geographic spread, the public health interventions that are being taken across the different response pillars. And these situation reports are widely used by our ministries of health, the WHO, and other partners during our coordination meetings, as well as for planning and resource allocation. As more and more reporting streams and tools are introduced, one of the things that we see is data management challenges also become more visible. At any given point in practice, countries will be dealing with the use of many different Excel sheets. Some of them don't talk to each other, paper forms, separate databases. There are delays in reporting. There are connectivity issues, and oftentimes we have electronic tools and digital platforms that do not fully communicate with each other. But at the same time, we're also trying to manage other important concerns around maintaining the privacy of data, since sensitivity of different locations. We have seen some Ebola treatment centers being torched by communities. And so some of the key priorities for addressing this includes trying to make sure that there's better governance for what data is shared, what data is made public, what are the identifiers that we use to cross-link information, what are the validations that we have, do our tools support offline capabilities for usability in areas that do not have internet coverage, as well as the interoperability aspects of how do we get our tools and our data systems talking to each other. So to help address these challenges, countries and partners will rely on a combination of tools, standards, and operational guidelines. These help to standardize the approach towards data management. And we know in outbreak settings, we certainly try to make sure that our tools are easy to deploy, they're easy to use, preferably tools that our healthcare system stakeholders are already familiar with, tools that are also sustainable over time. And in our experience, we find that most times having the simple, easy to use tools is far more important than having very sophisticated tools, especially in emergency settings. So WHO and partners.
1 minute for wrap up.
WHO and partners support member states with a range of outbreak data management tools and technical guidance. There are a number of tools such as GoData for case investigations and contact tracing, DHIS2, EWAS in a box, and other operational standards, guidelines that WHO publishes. Some of these tools whilst we think of the digital tools, even with this increasing digitization, we still have the paper tools that play a major role in managing data. In many field settings, paper remains a very practical option and also is very quick, but it also comes with its own challenges around transcription, standardization, data quality, and so on. These are some examples of some of the commonly used tools. So this is a case investigation forms. These are also very important blueprints for the electronic systems, where developers would take these tools after they've been reviewed by public health authorities, and they use this tool, these paper-based forms, as a standard for creating their electronic versions of these tools. So these are case investigation form with detailed epi exposure information, our contact listing forms, helping to identify and list the contacts or to conduct the daily follow-ups. One of the major WHO-supported outbreak tools is GoData. This supports case investigations and contact tracing, as well as laboratory, and offers various features such as the visualization of our chains of transmission, as well as managing the daily contact tracing and contact follow-up. We also have a lot of integration with other tools. So there's good integration with tools such as Kobo Collect, DHIS2, and other platforms. We also have the DHIS2 Outbreak Mat. This is a tool that has been developed by the WHO hub in Dakar, which is useful for managing cases, the contacts, and the laboratory, as well as aggregating and producing daily summaries. We can see dashboards such as this one, which provided a rapid situational awareness through the visualization of trends, summaries, and other interesting indicators. That's an example of the data entry form. And we have this data. We're not just trying to collect it, but we also now transform it into other information products that would support our operations and reporting. So just in closing, in conclusion, we can see that data management it's not just about collecting data, but it really is about enabling faster and better public health action in the context of an outbreak. And we certainly see the benefits of countries taking a long-term view to the tools that they choose, the tools that they use, as there are benefits with having tools that are sustainable, tools that stakeholders are familiar with, because at the end of the day, we know that better data would help our teams to respond faster, improve coordination, target our interventions, and ultimately save lives. Thank you very much. Over.
Thank you very much, Tamai, for this very important session about the data management and analysis. Now, let's take few questions, and I will be asking all the panelists to be ready to take notes, but also to answer. So I have already a few hands up. Let's start with the first one in my screen here, who is Evanilda Santos. If you can take the floor. Evanilda Santos. Can you open your mic? Okay, let's move to the next one, which is Jamal Yusuf. Okay, let's wait. Evanilda Santos, over to you. We can't hear you. Okay, let's move to Jamal Yusuf, then to Makuela. Jamal Yusuf, if you can open your mic, please. Jamal Yusuf, can you hear us? Okay, so let's start with few questions that are in the chat here. So before our team see if there is any issue with the mic. So the first one here is, are there any exit control measures implemented at the point of entry by DRC and Uganda? If yes, do you mind sharing what measures are implemented? Are there any screening measures implemented the countries bordering the affected countries? So I will ask Dr. George to answer to this question. Dr. George Williams, over to you.
Yes, so I would say yes, the DRC has put into place screening measures at various points of entry with support from ROM, WHO, and other partners. That is one of the key recommendations of WHO for exit screening. And as you may know, at some point, the Bunia airport was closed. Now it has been reopened, and the exit screening measures have been reinforced to allow travelers to move, but to ensure that they are screened properly. They are provided with the basic risk information associated with the disease before they can be allowed to travel. Over.
Thank you. Thank you very much, Dr. George. The second one here is from Linda Kanzara. So a couple of questions and clarification. It is for Dr. Freddy Banza. Are the contacts supposed to be followed up daily? is the tracing for high-risk contact the same as those of lower risk, or is there an exception for more intensive contact tracing for high-risk contact? What are the retention mechanisms to ensure that contacts are not lost? So, Dr. Freddy Banza, if you can just take 1 minute to try to answer to those questions. Over to you, Dr. Freddy.
Okay, there are two questions. I don't know if I will manage to respond in 1 minute. So thank you for your question and interest for this topic. Yes, all the contacts should be followed this for 21 days, and then for the high-risk contact, we can follow up. It's up to how we define our work with the team. Most of the time, we recommend that they should be followed up twice, in the morning and then in the evening. But according to some of the contexts, some of the contacts have been followed only once per day. But if like we found that it's very high risk contact, and then that need to be followed twice, and then we need to do so. So the team in the field will agree on how are they going to proceed on that. But most of the time, we recommend to follow up in the morning and in the evening to make sure that there is no symptoms. And then if a contact, how to make sure that the contact cannot be seen, or cannot move. The most important is to make sure that when a person is a high-risk contact, we need to give a lot of advice so that we can prevent a movement. The person should maybe self-isolate or make sure that when he starts having symptoms, he report that. In some of the cases in the past, what we have done was to provide some necessary items to those high-risk contacts, because they were saying, no, if I do not go to work, if I stay here, I will not get, something, food to eat and whatever. So it's important that we give advices so that they can remain at the same place. They do not move too much if they are at high risk contact, so that we cannot lose them. But in case they want a contact want to move, we can always get the details of the program where they are intending to go, so that we can communicate with the person who is with the local authority, health authority, who are in that area where the contact is going, so that it can be followed up that side. I don't know if I have touched all the questions.
Thank you. Thank you very much, Dr. Freddy Banza. Because of the time, what we'll do is to take all the questions and to answer them offline. We will share with you the report, but also the answers for all those questions. Now, because of the time, let me give the floor to Dr. Etienne for next step, how the WHO is seeing surveillance for these BVD outbreaks, and also if Dr. Marie Roseline is there to get the floor for the closing remarks. Dr. Etienne, over to you.
Okay, thank you very much, Dr. Saliu. So basically, since time is already up, we want to really repeat the message that we have all been communicating already, that this is a very important moment for everybody, and we should really be strengthening surveillance. So just briefly, obviously we are, as the presentations showed, there are countries with active cases, at least DRC and Uganda, where the aim is really to contain the transmission very fast. And so this is really top priority countries, of course, where we are focusing support in terms of sustaining the multipolar response, surveillance, real-time decisions that really can help us move ahead. Prioritizing the confirmation All of that has been said about case investigation, line listing, and contact monitoring. All of that has to happen. And of course, the use of analytics to really to identify, the bottlenecks and really make sure everything is in order. And then there are countries with immediate borders at of high risk. So those are really where we want to detect importation early. We know how, for example, Uganda case #1 happened. So really how we can really make sure readiness is in place in border districts, looking at the mobility corridors exactly, but also prepositioning rapid investigation, specimen referral, and contact tracing already arrangements. Establishing routine cross-border information exchange with affected countries and our partners involved. And then we also have another set of countries that have direct borders or high connectivity. So they don't have immediate neighbors, but they are still also a priority countries where the aim here is really to ensure rapid verification. And then all of the other countries, as has been discussed, is to sustain the regional vigilance, really maintaining all that have been said about readiness, but also routine surveillance through the IDSR, event-based surveillance, and so on. And also making sure teams are well prepared in case something happened, to make sure things can be quickly reported. And again, making sure those case definitions that were discussed are already shared and reinforced for everybody. So in the interest of time, we will stop here, but this was really a very important webinar. I think our Red will not be able to come back to close since she is now in a press briefing with the RD. So Asalu will certainly end here. I don't know if you have something else to say before we end. Thank you. Back to you.
Thank you very much, Dr. Etienne. I think it's just my pleasure to moderate this session, and thank you very much all the participants for your dedicated time to attend this important webinar. We promise that we will be sharing all the materials, the slides, and also answers to the questions that you have asked. So thank you very much. Over to you, Dr. Etienne, to close.
Okay, so again, thank you, everyone. This was really a very important meeting, discussions. We heard a lot. And so just to say that we are here to support, and we'll continue the communication throughout the other means. And of course, we have scheduled webinar series that will continue throughout, and our colleagues will actually begin to discuss other subjects that are related to the outbreak as well. So thank you, everyone, and have a good rest of your day. And bye-bye.
Thank you. Bye-bye.